Hello, this is Alfons Roeksonsmoor, and today's topic is postnatal care, mind and body. A very important topic, and I decided to split it in two to make sure that each video is not more than 20 to 25 minutes. You're about to do a postnatal ward round, and what should you ask for? What and how should you check when you do a physical examination on day 2? This lady had a normal vaginal delivery, had a right mediolateral episiotomy, and a healthy baby girl of 3.7 kilos, and she commenced breastfeeding. You are about to do your ward round, and how would you go about this? Step 1, prepare. Do your homework. First, in the chart you will find what her body temperature was, blood pressure and pulse rate, and if need be, respiratory rate. Look at the case note entry made by midwives, nurses or other health professionals such as physiotherapists or a social worker. Are there any special circumstances or observations regarding her mind and body? Not being prepared is a recipe for doctor's embarrassment and will erode trust in you. Here applies as well that prevention is of course better than cure. When you're in the room, step 2, what questions do you ask? I would like to suggest to you to do it in a systematic way from top to toe. First questions would address her general well-being, her mood. 2, questions about her breast and the breastfeeding which she is trying to commence. 3, the involution of the uterus and the lochia, the amount, the color and the smell. And what I will address in part 2 is how do any scars look like, such as the episiotomy or the lower segment cesarean section incision. And 5, what about her legs? It's easy to remember these 5. You only need a full hand to count. You don't need an app or a computer. Step 2, the room. In the room, history. Ask for her general well-being, her energy level, her mood. Tiredness or fatigue due to sleep deprivation and the fact that she just had a delivery is quite common, and sometimes it's hard to discriminate between what is normal and what could be pointing at an iron deficiency anemia or hypothyroidism or more rarely cardiomyopathy. So there is a transition between usual tiredness and pathological tiredness. How to discriminate between baby blues, which are quite common, from postnatal depression or even symptoms of pointing at psychosis. I would recommend you to always explicitly inquire about her perception of labor and delivery. Where is she on the scale from I'm not happy or I'm on cloud 9? In my opinion, it's hard to predict. Actually, you're not able to predict. Some women are very disappointed at what appears at first glance a normal vaginal delivery, and others are really happy even after they had an instrumental vaginal delivery and a postpartum hemorrhage. Not including this in your thinking will mean you run the risk to miss the boat. She feels not understood, she's dissatisfied, and as are family members, and it is hard to restore trust. And of course, I would like to confirm the obvious: be always prepared of privacy and confidentiality. If it's not in a single room, the privacy is as thick as the curtains. Step 3 in the room, examination. I recommend that you follow the same from top to toe 5 items as we discussed before. Especially you should focus on body parts if the history reveals something is not right. But I would recommend for junior doctors for the first couple of weeks Check, look and palpate every day to familiarize yourself with what is normal and what is not. 2. Breasts. Is it normal? Is it just what we call engorgement? Are there cracked nipples? Or are there signs of mastitis? What the uterus? Is the uterus contracting down nicely? The involution is happening normally or not? What is the amount of lochia? What is the color and the smell? Scars. Check vaginal or perineal tears, the episiotomy and the lower segment cesarean section. Check that explicitly, especially when you start in your career. Legs, last but not least, number 5, check for signs or symptoms of deep vein thrombosis. Something else I would like to confirm, the communication skills, your body language. Usually a lady postnatally lies horizontal and flat in her bed. She is per definition low, and you are in a vertical position and high. That means there is from the beginning already, there's not a level playing field. I recommend to you lower yourself to our eye level. That means you communicate horizontally rather than vertically, and remove this obvious communication barrier. To make this easy, I would recommend you to sit down. Take a chair, sit down, which means that you tell her, without saying anything, I do have time for you. You're important for me. Rather than nervously hopping from one foot to the other, or even worse, flicking through the case notes whilst you walk around. Which tells the lady, I'm in a hurry. I'm not really here. I'm not really with you. 2 minutes spent sitting down is quality time for you and your patient. Don't forget the obvious. Narrative medicine. How's your baby? And if you're really in a good mood, you could actually inquire how her partner is or family members are. We doctors at times are so focused on her body temperature, her blood pressure and full blood count that we might forget what is really important to her. So please turn off your pathology of seeking radar and co-enjoy. By the way, this baby is not a day 2 baby, but just to share that beautiful ray of sunshine with you. Her mood and mind. The first item. What do we mean by baby blues? Baby blues happen in about 70% of women after they delivered, and usually it occurs between day 3 and 5, but most of the time before day 14. There are mood swings, she's emotionally more labile, she's tearful. And by the way, you might not see this in the hospital because of the early discharge, but it's good to know this. Delivery, even a normal vaginal delivery, is a life-changing event per definition. Adjustment is required, emotionally, psychologically, and physically. There's a sudden drop in placental hormones which contribute to the baby blues. The transition into motherhood is not romantic at all. Let's be honest. You don't sleep for longer than 2 or 3 hours when the baby wants to have another feed. Moreover, there is no mother or no grandmothers around you or village people like what we had in the past. Management, acknowledge that this is normal, physiological, validate, reassure and support. No specific treatment and most certainly no medication is required in most instances. We need to differentiate the baby blues from postnatal depression. Postnatal depression where there is an obvious adjustment disorder with a depressed mood. This occurs in about 15% of women. There are obvious symptoms of major depression. It occurs in principle within 12 months after delivery and lasts at least for 2 weeks. Interesting, while a lot of psychiatric conditions are linked with a stigma in society, that's not the case for postnatal depression. Most people understand that this is a life-changing event and hence can result in depressed mood and disappointment, bitter and deep disappointment and low self-esteem. What is the etiology? Many factors play a role, such as biological. Usually there's positive findings in the family history, but also cultural and psychosocial factors might be at play. What are management options? In general, it's good to acknowledge this, advise about a healthy lifestyle. It appears to be a motherhood statement, but still good to make explicit. Tell her about healthy nutrition, encourage her when she goes home to do some brisk walking, find social support from friends or family, and encourage or even force herself to do at least a few pleasant activities every day. That might be hard, but really important to encourage. Nowadays we have very good psychological treatments available. One of them is mindfulness. A few dot points to explain that a little further. Acknowledge the fact that you feel down, that you feel depressed, that you feel anxiety, that you are anxious, which in principle are irrational thoughts, but acknowledge them first. Then there are different ways to diffuse those thoughts racing through the brain, and it could mean you diffuse the brain to continue to generate those negative thoughts. Sometimes it's helpful to reserve a certain time in the day to think about your worries rather than worrying 24/7. I think it's an important step to learn the woman, the patient, to self-manage this condition. Eventually, gradually, she will learn the skills to cope with this condition. And hence, this is an important long-term investment. It's like when you practice to run a half marathon. That doesn't happen in a fortnight. It needs practice for a long time, and then you will get there. Medical treatment options are available. One of the most common is, of course, the selective serotonin reuptake inhibitors, SSRI. Interesting, in well-executed randomized clinical trials, SSRIs are not much more effective than placebo, so the efficacy is overemphasized. It's a typical part of what I call pills and procedures, P to the power 2 medicine. Of course, if you would identify major depression symptoms, suicidal thoughts, referral to a psychiatrist and most likely admission are warranted. That concludes mind and mood. Let's go one station down, the lactating breasts. Here's a picture of a diagram of the breast. The volume of the breast is mainly determined by fatty tissue. Here in purple depicted the lobules. Milk is collected in the duct, and then eventually this is the outlet at the nipple. How do breasts look like? For instance, here on day 2 after delivery, the breasts are engorged, as we call it. They're swollen, they're painful, and you see the veins, the superficial veins, very clearly expressed here. This is a physiological condition. The milk starts being produced and it results in internal swelling. A low-grade fever up to 38.5 is quite common. The management of this condition is explanation and reassurance. Ice packs can be helpful, simple analgesia, but the best advice is to encourage that the baby empties the breast, because that will alleviate most of the symptoms. So physiological, it is no reason to discontinue breastfeeding the baby, to the contrary. This is in stark contrast to this picture, and it's a quite obvious picture where you see this part of the breast is red, inflamed. This lady would have also symptoms of fever, sometimes even chills and tachycardia. So this is obvious a mastitis. The most likely cause is the Staphylococcus aureus, which is transmitted from the infant's nose and throat. And the management is flucloxacillin, capsules of 500 milligrams 4 times a day for about 5 days. Just penicillin would not be sufficient because the Staph aureus, as you know, produces penicillinase, which makes the penicillin ineffective. Important to continue to breastfeed and to encourage effective milk removal. If breastfeeding of the baby would be not sufficient, temporarily the use of a breast pump can be encouraged. Here the rule of thumb is after 78 hours of antibiotics one should see a clinical improvement, so less pain, afebrile, less swelling. If not, we have to consider the formation of an infiltration or an abscess. It's quite common to request an ultrasound scan to find out whether there is an abscess which could be drained. At the same time, one could request a radiologist to drain the abscess if that's confirmed. If that would not yet result in an improvement, most often surgical incision and drainage are warranted, and most surgeons would like to take a biopsy from the abscess wall, because this could be a typical presentation of breast cancer. So keep that in the back of your mind. And of course it makes sense to consult with your breast endocrine surgeon or your surgeon. Be aware of the so-called systemic inflammatory response syndrome. And I will discuss that later on in part 2, where we discuss as well the endomyometritis. Station 3, the uterus, the womb. Some women might complain that their tummy hurts, especially when they start breastfeeding the baby, which sometimes results in wanting to discontinue with breastfeeding the baby. How would you manage that situation, and how would you counsel her? Well, if you know the physiology, you will know that this is a perfectly normal reflex. The uterus contracts in response to the oxytocin release in the posterior pituitary gland, also called the neurohypophysis. The oxytocin stimulates on one hand contraction of the uterus, physiological contractions, intermittent contractions of the uterus, and on the other, the so-called milk ejection reflex in the mammary glands. To refresh your memory, you see a diagram of the pituitary gland, posterior pituitary gland, which releases both oxytocin and ADH. And as you know, the anterior pituitary is well known to release, for instance, LH, FSH, TSH, and also prolactin, to mention the most interesting one from the gynecological point of view. Please explain this phenomenon in plain English without showing your knowledge about the neurohypophysis, etc. The uterus should be palpable close to the pubic bone on day 9, 10 after delivery. Here you see systematically that every day the uterus comes down further. Important to check that with your palpating finger and hand to ensure that this process takes place normally. If there is sub-involution of the uterus, that could be the first marker of incomplete placenta or an infection. The endomyometritis. The diagnosis is a combination of 1. Fever, febrile illness, over 38-35 degrees Celsius, between day 2 and day 10. Lower pelvic abdominal pain, usually symmetrical. Offensive lochia. The smell is usually caused by the activity of anaerobic bacteria. And on palpation, the uterus is tender. The uterus is centrally located and the pain is centrally. When you would check white cell count and CRP, those are increased. The more the endometritis, the longer it has lasted for and it has invaded myometrium, the higher especially the CRP will be. Taking a microbial swab is not very useful because the swab will be contaminated in the vagina. So unless you would use a double lumen swab. The treatment, any ideas of the treatment? We would give antibiotics covering empirically gram-positive and gram-negative and anaerobes. So no swabs are swabs are not useful. They don't guide your treatment. We would usually start with a combination of a cephalosporin or Augmentin duo forte, to cover the gram-positives, metronidazole to make sure you cover the anaerobes, and gentamicin for the gram-negatives. Check, of course, exclude first the patient is allergic to one of these antibiotics and your local guidelines for antibiotics, because that might differ from hospital to hospital. Commence the antibiotics intravenously. That means you have as quickly as possible an appropriate concentration of the antibiotic in the myometrium and endometrium. Switch to oral after 48 hours if she's clinically improving, so no more febrile, the pain is improving, etc. Analgesia, simple analgesia is usually okay. This concludes part 1 of the postnatal care, mind and body. We will proceed with part 2, where we will focus, where we make 2 little detours, little but important. Thank you.